is not an expert on a topic, right? I'm an expert in one area. Mr. B is an expert in another area. So we defer to expertise. The person with the highest relevant knowledge on the subject matter is the person that helps us make the decision. It's not even by being the boss, right? We're not saying because I'm the boss, I know everything. No, yeah. If the most junior person in the team is the one who has that experience, everybody defers to that person, right? It's not by title, it's not by rank. And that's what a high relay, and that's really what we are trying to build with this topic, right? So build a team that, as we said, preoccupation with failure and all these things that we've said. I've been talking too much. Any questions before I move on? Just to slow down a bit and allow people to make inputs. Any questions? Are we together? Am I alone?
We are together. No questions.
Sure.
We are
Okay.
together.
Please, if you have any questions for me, thank you. If you have any questions for me, put in the chat, okay? I'm going to move a bit faster now.
Okay, ma'am.
And if I'm too fast, please let me know. So let's move on now to the practical tools that we can apply as nurses in our day-to-day work that helps us really mitigate risk, right? We said we want to stop things from happening before they happen. And that's what we're trying to do here. So the first three tools I'm going to talk about are proactive risk tools. So there's something called failure mode and effects analysis. This essentially helps you to ask the question, I'm trying to build a service, or I'm trying to do this new thing in my department. What are all the possible things that can go wrong? I want to set up a new surgery service in my hospital. What are all the things? Do I have everything I need to carry out that service? Whether it's in terms of personnel, whether it's in terms of equipment, whether it's in terms of instruments, whether it's in terms of infrastructure, whether it's in terms of flow, how are we going to move through this theater in a safe way that ensures infection control? All the possible things that you need to think about for that surgical service to work. That's what an FMEA is about. So what are all the potential things that can happen? So one of the things would be that the theater is not safe, or we don't have a proper flow from clean to dirty or dirty to clean. The potential there is infection. So you now think, okay, what are the possible things that can lead to this infection? Is it the design of the theater? Do we need to look at the design? Is it the way people walk through, right? Do we need to train people to say, okay, this is where you enter, and this is where you go out from, right? And then if the process fails, what is the effect? We need to quantify that effect so that we know which ones or which failures you need to go and tackle first, essentially, because you cannot really, and we must be conscious of that as well. You honestly cannot solve all the problems at the same time. So you need to go through or go with a phased approach in most instances when you're trying to do a failure mode effects analysis, because there are so many issues that you would identify. But what you need to look at is which one has the most negative impacts, which one has the most frequency in terms of occurrence, which one do I need to deal with first. I'm sure we'll have another session that goes deeper into, maybe like a workshop that goes deeper into how to do a failure mode effects analysis and what to expect out of it in terms of outcomes and how to roll it out in your organization. This is not the session for that. This is just for you to know that there's something called FMEA. I'm going to stop there. There's also risk assessment, which is routine risk assessment. I think I've hinted on that already, to say, as a nurse manager, as even a ward nurse, a nurse officer, when you come to work, you need to go around to see how many patients do I have today? What's their acuity level? When I say acuity level, is what does this patient require in terms of clinical care? How sick is this patient? What type of care does this patient require? Does this patient require intensive care? Does this patient require routine medical care? So, for example, a patient who was admitted 5 days ago for malaria, who has received the full course of anti-malaria and is possibly going on today, just has one more dose of anti-malaria to take, and the patient is going on today, compared to a patient who was brought in yesterday with a brain injury. The acuity levels are different. The attention they both require is different. This one that is going on today with malaria can even take his drug by himself. So you need to channel more resources to that person who requires it. That's the essence of the risk assessment I'm talking about. Different patients have different characteristics. You need to be able to put them down to say, these are the things this patient require. Do I have the resources to deliver on that? Right, that's for the clinical bit. But beyond the clinical bit, you also need to look at your environment. What's in this environment that will cause risk to me? or that will cause harm to me or my patient. We need to, as a nurse, it's part of our work. And when we identify this risk, we need to speak up and say, something needs to be done about it. Maintenance, say, come and fix it. I'm seeing wire hanging here. Somebody can get electrocuted. Things like that, Environmental scanning, as I said, there's wet floor, there's tangle cord, so many different things. So essentially, it's being aware, being conscious, and looking out for issues and solving problems before they happen. And when we talk about the clinical bit, I just wanted to give you guys some examples of clinical risk assessments. I already talked about falls. Someone mentioned pressure ulcers. There's violence and assault. There are so many others. Infection control risk, central line infection risk, VTE risk, venous thromboembolism risk, sepsis screening, so many risks that we need to think about as healthcare professionals when we are going around and making sure that our patients get what, even nutrition risk. Some patients are not eating properly. And if you don't assess them, you will not realize that it's a risk. All your all your treatments won't work because nutrition is poor, for example. Okay, so when we talk about, I mentioned communication earlier, and I talked about ESBA. So ESBA essentially is a communication strategy that has been proven to be effective in making sure that you communicate in a concise and logical manner. And concise and logical means that the person who you are giving that information to gets the facts, gets the real information that they can use immediately to do the work that they need to do for the patient. Okay? So we propose it because it's a very good tool and a lot of organizations are already using it. So when we say ESBA means the first thing is situation. Okay? And I put this slide, I hope you would all get all these slides. I don't know. I hope they share the slides with you so that you can always go through this later. So situation, essentially, you have to identify yourself, identify the patient that you are referring to, what is the symptom, what is the severity. That's the situation. Straight to the point. You don't want to be giving long story. Nobody has time. As I said, we're working in fast-paced environments. We have a lot to do. So nobody has time for stories. So you say your situation, your background, for example, date and time of admission, what's the admitting diagnosis, what's the relevant medical history, laboratory result, if necessary, if relevant to what you are communicating, notable changes, right? And then what's your assessment of the situation? What's your suspicion? What are you concerned about? That's where you state it. And then you do your recommendation, right? Very clear. What is your recommendation? Do you need the doctor to come and see, for example? Or are you saying the patient is in pain, I need pain medication? What's your recommendation, really? And the purpose of this tool is to structure our communication, as I said, and make sure that we're communicating the right thing, actionable things that will, improve the efficiency of our communication and make sure that the person actually understands what it is they are trying to say. So the other communication tool that we can do, and I'm sure most of us do, would be our daily safety hurdles, where we check in with ourselves to say, okay, brief team meeting, what's going on? I was managing patients A, B, C, and D. You are managing patients 5, 6, 7, and 8. So yeah, what's going on? So that you can reallocate our resources. Maybe 2 of these other patients are fine and they can walk around on their own, but somebody is deteriorating somewhere else. That's where you quickly arrange yourself, move around, allocate your resources as needed, and keep doing the work that you need to do. Okay. How many minutes do I have, Ijoma, please? How am I doing on time? If you leave me, I'll be here till next week. Okay,
You still have about 30 minutes.
Good, thank you. Okay, I'll be rounding off shortly. So practical tools and strategies for nurses that we need to think about. One of them would be our clinical practice strategies. So I think I already talked about following guidelines, following protocols, following best practice to say, want to dress a wound, for example, what's the best way to dress a wound? Are we using, some people say use hand glove only, sterile gloves. Some will say we're using forceps. Some will say we're using normal saline for the solution. Some will say we're using, some will use honey. They're different things. I understand that there are different types of wounds and different types of wounds require different things, but do you know what they are? So that's what this question is about. When we say clinical practice strategies, what is the best way of treating this patient in front of me right now? And that's what you need to follow. But if you don't know it, then you cannot deliver it. And that's the challenge to all of you today, to say, even if your organization does not have those documented guidelines, pathways, protocols that are evidence-based, you can develop them. As you develop them, you're also developing yourself. And nobody's going to take that knowledge away from you. And what's most important is start practicing it. As you practice it, pull your other colleagues along to work with you, and you will see the outcomes. Once your patients are happy, you're happy, right? And that's the essence of all of this. Another core practice or clinical practice guideline that we can think about is medication administration, because as I mentioned, is one of the key issues or key areas of issues that we often have as nurses and as healthcare providers. They say there are 5 rights of medication administration. There are so many rights now. I think they are now up to 9. So the first one was right patient, right drug, right dose, right route, right time. Now the new ones are right documentation, right reason, right response or evaluation, right to refuse, right assessment, right patient education. There are so many rights now of medication administration. But if you are not reading and you're not exposing yourself, you won't even know that those exist. Okay, so the essence of what I say is there's a science behind what we do as nurses. And it's our responsibility, individual responsibility and collective responsibility, that to make sure that we identify what those scientific ways are, or those scientific reasons behind what we do. So that when we apply it and we're doing our work, as I say, nothing is a science and an art. We're doing our work in a way that gives us the results, that shows us as professionals in our different fields. Okay, the next one is infection control, right? When we talk about clinical care, fundamental to excellent clinical care is infection control. So how are we making sure that we're following the WHO, for example, hand hygiene steps? What aseptic techniques are we applying when we're doing our day-to-day work? I mentioned before how we manage our devices, especially devices we move between patients. How do you make sure you sterilize it properly? Ordinary or BP cough. Are you supposed to take BP cough from one patient to another without cleaning it? You know, so there's science and techniques behind these things that we need to apply in our day-to-day work. Okay. Yeah. The next tool that we need to think about would be technology. And I talked a lot already about documentation. If you did not document it, you didn't do it. No matter if they call you to any court of law today, if you didn't write it, it's not by I did and I didn't do that you're saying verbally. Nobody's going to take anything from you. Okay. Document it. Okay. I know not all of us probably use EMR. Some of us are still dependent on paper. That is fine. Whether you're using EMR system or paper documentation, you need to write things properly. Okay. And I said before, technology is your friend. Use your phone to remind yourself of certain things. You're not Superman. You can't remember everything. Remind yourself to say, I must go and reassess this patient's fluid intake and output by so time. Set a reminder. That's why technology is there for you. Okay, use your checklists, use your EMR alerts, and all of those reminders essentially effectively. And like we said, if it's not documented, it's not done. I already talked about incidents and near misses. Capture and learn from them. Okay, so what you're reporting is what happened, as well as what nearly happened, what almost happened. Okay, so incidents would be you have already administered the wrong medication. That's an incident. But I nearly administered the wrong medication. It's still an incident. Fill it in. Because as I said, that's where you can go back, review to say, these medicines actually look alike. I nearly gave this. Next time, let's separate them. This is where we're now keeping this one. Just to bring the team together and help them to learn from what has transpired. Okay. So the next thing is, how do we embed all of this into our daily nursing practice? Right? So the first thing is we need to build the habits of prevention. All of these things I've mentioned already is just to call our attention back to how we can start to practice all of these things daily. Okay, first, we need to build the habit of prevention. And that's the first thing there is being mindful, being conscious, double check, realize that that you can make mistakes. As we said, you have to be fundamentally conscious of the fact that things can go wrong, that you as an individual can make a mistake. So you have to sometimes always pause and say, where am I? Am I trying to give a patient this? Which patient am I giving? Where is patient's note? Let me see. What did the doctor write? Let me check again, right? So double check before you act. Always, always double check. And in most cases, peer review, get someone else to come and look at it, right? So that you reduce your own biases. As I mentioned, we have cognitive bias as human beings naturally, right? And we need to overcome that. Okay, so cognitive bias is essentially a predictable way of thinking where your mind is already set in a certain way without you even knowing. So, for example, there are different types of cognitive bias. I put 2 examples here. So, confirmation bias. A nurse assumes that a patient's shortness of breath is due to anxiety because you knew that this patient has anxiety disorder because they came on admission 2 months ago and you already know the patient. And you say, oh, no, my, that's what they do. He had it before. It's normal. It's normal. It will calm down. It will calm down. And then you go and overlook the fact that this patient has new symptoms that you haven't seen. You didn't check, right? So you have overlooked the fact that he has new crackles in his lungs, that he has delayed capillary refill, which would have prompted you to take action immediately. Okay, so we must be conscious of that. The second example I put there is anchoring bias, where maybe during the previous handover, one of the nurses just mentioned to say he's probably dehydrated, and you anchor onto that information, whether true or false, and throughout your shift, you're just saying patient is probably dehydrated, and you're acting based on that without doing your own assessment to confirm what's really going on, right? So you've missed that the patient had fever, you've missed that the patient has low BP, you've missed that the patient's blood pressure is going up, or that the heart rate is going up, and things like that, which would have prompted you to take actions earlier. So we must be conscious of our cognitive bias. Don't just assume, right? You should be working based on the facts in front of you. That's the essence of all of this, right? The second thing is we must empower ourselves and other nurses that we work with to halt unsafe practice. If they feel that something is wrong, they need to stand up and say, please stop this. Can we look at it in a different way? This is what I'm seeing. This is what's going to happen. People should be able to speak up. Okay, so a nurse can say, I'm not clear about this doctor's prescription, so I'm not going to administer it. No, doctor, please, can you help? Not to say it rudely. We're not fighting. We're only supporting one another, right? Essentially, it's the patient that is the focus. I think that's what it is. It's about giving the best to the patient. So please don't fight. I don't encourage people having unnecessary rancor and all of that. No, it's not about your ego or my ego. It's about to say, sir, can you help me look at this prescription? Something is wrong here. It's not quite right. This patient should be on 10 milligrams. I'm saying 100 milligrams. Are you confirming that I should give 100? So, like that, so that you are clear without, so that you don't make errors, right? And then the final one is leadership. Some of us here at senior nurses, where we are coming from, it requires visibility. People need to see that you are doing things in a certain way and they copy what you are doing. We have to model it as leaders. We have to be visible. We have to show support. And one of the ways of supporting our people is celebrating them, especially when somebody reports a near miss. Because if it's a near miss, that means nobody would have even known that anything happened. The person can keep quiet. But if somebody intentionally reports a near miss, you must celebrate that person to encourage more team members to keep reporting. Okay, so I'm going to look at some case studies and give us opportunities to respond to some of the questions. The first case study is about a nurse. Are we paying attention, please? Confirm that you're paying attention. Just say yes in the chat. Are we still there?
Yes.
Yeah, yes,
Good.
we are here. Yes.
Awesome, awesome. Thank you so much. Thank you. Well done, everybody.
You're welcome.
So the first case study is about a nurse on a busy medical ward who is preparing to administer an antibiotic to a newly admitted patient. The EMR displayed an alert for penicillin allergy, but due to multiple pop-up messages and time pressure, the nurse quickly bypassed the alert. Just before giving the dose, another nurse asked her, "Isn't this patient allergic to penicillin?" prompting that first nurse to recheck and prevent a potential anaphylactic reaction. This case was subsequently reported as a near miss. So the discussion question is, what proactive behaviors helps to prevent harm in this situation? Who can answer that? What proactive behavior?
Prompt by the nurse, the nurse that was sitting close by.
Yes, prompt recognition. Somebody recognized it and spoke up. Right? Good. Any other thing? Team vigilance. Somebody was paying attention. Right? And then the learning mindset, the fact that the first nurse took that feedback and acted on it to say, oh, okay, let me recheck. Because some people might say, how do you know is it correct, or don't mind, the system is wrong, or they start having an argument there. But this person took the feedback, went to recheck, and made sure that she gave the correct job. So that's team vigilance, the documentation of it, learning mindset, and all that. That's good. So how can nurses manage alert fatigue? Because see, the real bottom, you see, it's not just about the two nurses, there's an issue. They were having multiple alarms, and they were tired of the alarms. That's why she just kept, she just dropped the pop-off of the alarm, right, without taking it seriously. So how can nurses manage such fatigue going forward? Any ideas? Do we know what alert fatigue is? Does anybody know what alert fatigue is?
Getting tired of responding to alerts. Maybe there are so many alerts prompting up.
Yeah. So I think, what can we do as nurses to prevent that? Because if alarm fatigue is happening, then we're exposing ourselves to unnecessary risk. That means we don't know when the serious alarms are going off or when the minor alarms are going off and all of that. So what we need to do is really prioritize our clinical awareness. Okay, when a system that we built alarms or alerts, it means that something is wrong. So we need to build that consciousness within our teams to say something is wrong, check, right? It calls your mind to go and check again, no matter how many alarms you have. I know it's not easy, but as healthcare professionals, we must prioritize that clinical awareness, okay? Second, as I said, is pause and verify. Don't be too quick to close the alarm. Check. There's always time to cross-check, right? Before you give the wrong medicine. And then ongoing education of our team members as well to make sure that they take alarms seriously. But beyond that, I think the other side of it is then to say, what alarms are popping up? If we don't need the alarms, remove them. If they are not for critical issues, right? You need to prioritize to say, okay, when it's critical, when you need to focus, this is the sound it makes. If it's just to tell you that there's some minor variation in patient's vitals that is not significant, then this is the sound it makes. So when you hear the critical one, you know that this is critical. For something like in this example now, allergy, right? So maybe you should have a different sound so that once you hear that, you know that I can't play with this one, right? So essentially, it's about managing our technology, balancing technology with our efficiency, with our mindfulness, and also being patient-centered in what we are doing. So the third question is about what system changes could reduce. I think I've talked about some of them already. So it's about optimizing our EMR record system, differentiate the high severity alarms versus the low severity alarms. And then hard stop, as we said, audit feedback, making sure that we are giving people feedback, right? When we come to audits, or if you have a system that allows you to say, okay, how many times are people shutting down the alarm or not responding to the alarm? You can do an audit that shows that, and then you can see, okay, what's going on? Why are people doing this? What's the issue? Are the alarm systems not working properly? Which ones are not required anymore, for example? Which ones can we take down? We can redesign the system to make it work for us, essentially, is what I'm saying. So the second case study is about during an evening shift, and a 78-year-old patient fell while trying to walk to the bathroom unassisted. The patient has been assessed as moderate fall risk, but the call bell was out of reach and the bed alarm had been turned off to reduce noise in the ward. Fortunately, the patient suffered no major injury. So the first question here is, what preventive measures were missed before this incident? Any ideas? What did we miss? They've gone to sleep.
Alerting
Please
system.
go ahead, Ugochi.
Yes, I think that there was no alert system. The client couldn't reach out to anyone when he needed, which she needed help. So if there was a call bell, that was one of the preventive measures that was missed, and no one was around to help too.
Exactly. Yeah, very good. Thank you for that. Yes. Very good. And also these days, we now have bed alarms, chair alarms, especially for patients who are elderly like this and at risk of falls, right? And then the other thing is, did we even assess this patient properly? If we say moderate risk of falls for a 78-year-old man. Anyway, well, it depends. There are many 78-year-old patients that are strong and can move unassisted, but moderate fall risk, we need to think about it to say, especially if this patient has had surgery, for example, you cannot assess him as moderate fall risk. It should be, high fall risk, right? So that's on their side. We don't know what else the patient has. Let me not go into that. But then beyond that, there are bed alarms now that when the patient is at fall risk, you can attach the alarm to the bed. So you know when the patient gets up from the bed. There are actually systems like that now. I don't know if we have it in a different hospital. Even chairs, well, you can attach it to the chair so that if the patient gets up from the chair, it alarms at the nurse's station and you can quickly go there to check on the patient. But as Ugochi said, most importantly, you've discussed with this patient, you know the patient can go to the restroom, but you know the patient needs assistance. Why did you keep the call bell away from the patient? Okay, so lack of easy access to the call bell was a problem. Also, we need to consider the patient's toileting needs and all of that. Anyway, we'll discuss that. So the second question is, how could proactive risk assessment and environmental scanning have helped? I think I'm going to answer that one because we're running out of time. So falls risk assessment, so the question to ask here is, did we do the fall risk assessment using a standard tool? Now, using a standard tool like the MOS scale, which is what we use for falls assessment, or any other tool that you're familiar with, right? Was it done properly, or the person just said off the top of their head, moderate fall risk? Okay, so there are standardized tools that we can use that assesses different components that we shouldn't miss out when we are assessing a patient for falls, for example. Environmental scanning, as we said, routine visual checks, and all that. They scheduled rounding. In this case, maybe the nurses should have assessed themselves or assigned themselves to do hourly visits to the patient's room to say, okay, this patient may need some support, so we need to check on the patient every hour to see if he needs help going to the restroom, for example, right? And then collaborating with the family of the patients. When you have this type of patient on the ward, usually their family members might be around. If the nurses are, in another room, for example, so could we have asked the physiotherapist to help out, or any other family member who was there to help out, that sort of thing. So the key really is making sure that we are proactive about it, and we're really assessing and taking action as we go. Okay. So the final one, case study 3, a nurse notices that the patient's IV line insertion site looks slightly red and the dressing is loose. The patient is afebrile, but mentions mild tenderness. The nurse immediately replaces the line, notifies the physician and other care team members, sends a swab for culture. 2 days later, the results show early infection, but it had been caught before sepsis developed. So how did this nurse demonstrate proactive prevention in this situation? Any ideas?
Okay, for me, I think she was able to make some reports. Like immediately she saw the incident, she took actions. She involved the necessary persons. She sent swab to the lab and also involved the doctor and also did the dressing. So she actually connected everyone. She didn't just keep quiet about it. She spoke up and the necessary actions were taken and the infection was controlled before getting into sepsis. So that's what I think.
Awesome, awesome. Ugochi, you should get a prize from this class. Thank you for that. Yes, early recognition and escalation, very important. Timely intervention. She acted on it. She saw something and she took action. And she didn't just take action, she informed the people who should be informed. Lab tests were done, all of that. And then adhering to protocols, because I'm sure they had a protocol for all of this. When you see this, take a swab culture. If they didn't have a protocol, I'm sure she wouldn't have done all of that, right? So she was adhering to safety protocols, and then they reported it as an incident, I believe, as well. Okay. So what factors might cause others to overlook this? There are so many factors, right? As we said, there's cognitive bias, cognitive overload, even time pressure. We're working in a high-paced environment. People are always doing different things, attending to different things at the same time. So The tendency of overlooking some things is there, right? Inadequate training as well, fragmented communication, so many different things would have made someone, I mean, even new, imagine if the nurse was new and that was her first time working in this world, she would have missed it. Okay, so there are so many factors that will make someone overlook this, and we need to be conscious of that. So how do we reinforce the importance of vigilance and daily line inspection? Essentially, is by making sure that, we said early identification, right? So when we identify things early, then we're able to solve problems on time. It's reinforcing accountability. She didn't just say it's red though, and she walked away. No, we're saying it's red. What am I going to do about it? So it's reinforcing accountability for all of us. It's promoting teamwork. As we said, she didn't just sit and walk away. She also involved the people who should be involved as well, the lab, the physician as well, and action was taken. Okay, and this also essentially links to the safety culture that we spoke about. It's about identifying a problem, doing something about it, learning from it, making sure it doesn't happen again, and all that. So just to pull all of these things together and just to extend from this third case study, I wanted to talk a bit about care bundles before we go. So we have something called care bundles, and which are essentially, I've been saying evidence-based this morning. I've been saying, best way of doing things. So these care bundles are established best practices for dealing with issues before they happen. Okay, so we have a care bundle, for example, to prevent central line associated bloodstream infections. We have a care bundle that helps us to prevent sepsis, or at least to catch it early and take action. We have a bundle that helps us to prevent surgical site infections. There are so many bundles like that. And the essence of the bundle is it gives you those key steps you must take in managing a patient along those lines, right? That way, you are giving the best to the patient and you are preventing the patient's condition from getting worse. You are getting excellent outcomes, right? And that's the whole purpose of it. So we're preventing harm. I know more care bundles will come out because this is relatively new in healthcare practice. Maybe not so new like that, but in many parts of the world, it's still new, right? So the key features of a care bundle is that it's evidence-based, as I said, based on research, it's proven to work. That's why they've established those steps that people need to follow. It's also actions focused because it tells you exactly what to do. It's very action focused and it's consistent because it has, as I said, it has shown results over time. And once you uniformly do it and you apply it, then you will always, almost always get the outcome that you want. Okay, and it's measurable. You can track your compliance because you can say, we have 6 steps for this particular bundle. Did I do step 1? It's a checklist. Did I do step 1? Did I do step 2? Did I do step 3? So we can monitor compliance. We can see, okay, how are we doing? Okay, which step is difficult to implement in this organization? Which step do I need to take out? Which step is not important for us? Like that. And then to say, how do we keep improving our practice essentially? And it's outcome driven, as we said. So it helps us to prevent complications. So I already give examples of the different types of bundles, preventing prejudice, the one for preventing pressure ulcers, there's one for preventing falls, there's so many of them prevent infection, central line infection, phlebitis, ventilator pneumonia, and so many other things. So there are so many care bundles. It's just introducing you to it. As I said, there'll be another class that will take us through in more depth care bundles. So we show you examples of what the care bundles look like and how you can apply them in your practice. Okay, I think that's it from me. So conclusion and key takeaway. I already told us at the beginning why this topic is dear to my heart and why it's important for nurses. We play a key role. We're fundamental in healthcare delivery. We're at the center of the multidisciplinary team. And prevention really is our daily nursing practice, our daily nursing responsibility. So the key focus is we must anticipate all the time, we must communicate, and then we must work together, we must collaborate. And every single nurse is a safety leader. I told you earlier, we are advocates for the patients, right? We're advocates for ourselves, and we're advocates for the organization, right? Because all of this we're doing is contributing to that high reliability organization that I spoke about. We all want the success of our organizations, and the bulk of it rests in our power to be able to change the dial positively and move things forward for all of us. Okay, so safety isn't an extra task. part of our work. It's our day-to-day work. It's how we do our work every day. So my challenge to all of us now, before I go, is we have to take action. Okay. And I need you to think about one action that you will take tomorrow to stop harm before it starts. You can put it in the chat. Tell us, what action are you going to take today, tomorrow, to prevent harm before it starts? So that brings me to the end. These are my references. Back to you, Ijoma. Thank you, everybody.
Thank you, ma'am.
So any questions, please ask.
Thank you, ma'am.
Okay, thank you very much, Dr. Vivian, for the wonderful presentation. However, I have a question, and I really love the presentation, especially when you talked about HRO, the Swiss cheese model, and all. So something came to my mind now, because if you want to make a change, maybe on a large scale, you have to start from small, likely from your own space and all.
Yeah.
So if you would like to make a ward, or maybe a ward whereby you're working, you want to make it an HRO, and then on a daily basis, when you report to work, you identify, you move around, you do your assessment, and you identify some risk, and looking at the barriers in the Swiss cheese model that you actually thought was, it's like, okay, there is likelihood of harm actually getting to your patients, maybe as a result of the policy on ground, maybe staff's not being adequately trained, the system or the standardization, everything. There is always like, there's kind of a fault, there's an ode to each of those barriers that you actually see. Now, and you as a person, you are a nurse that is a patient safety advocate, because as a nurse, take it or leave it, you have to be an advocate to your patients. So yeah, you're a patient safety advocate, and you've actually pitched this risk that you found out from your assessment, maybe to your ward manager or to your next in line. And upon reporting it to them, like, okay, can we do this? Can we do this? Can we do that? I'll be like, they've been doing that so far. The management is not responding. So what can you do? My question now is, what can you do whereby wherever you find yourself, you make that change, and the management will be able to consider your hacks or your request? Because I think it's kind of it's more of political or diplomatic. How can we actually attend to such matters? Because
we lost you. We lost your comfort. But I think I get where you are going to say there are some things not within your control sometimes, right? And you try so hard to try to get other people to see, and it's not working, especially people higher than you. So the way I would address that is start within your sphere of influence. If you can still hear me. Can everyone hear me? Because I suddenly lost comfort.
I can hear you, ma'am.
Perfect. So start within your sphere of influence. Don't focus on what you cannot control yet. Start with what you can control first. Within that your department, which one can you control? Focus on what you can control first. Second is you need to be able to show the people you are trying, because there are people you need to influence, right? Your bosses, to help them to see. So you need to tell them why, right? And that's where your data comes in. Show them the results. In the small one you have done, go and show them that this one, we implemented it last week. We did A, B, C, D, and E, and this is the result. And if we do this and this, because that's what leaders want to see. They want to see results, right? And that way it's not easy to change mindset. That's the toughest part of my job. And I'm sure it's the toughest part of most people's jobs. Managing people is difficult, right? Especially people who are stuck in their ways and stuck in their way of reasoning. And that's how all of us, to be honest. So it's a gradual process. So like I said, start with what you can influence, so that in your mind, the dream is alive, so that you can influence yourself and keep driving for that improvement, right? So you need to manage yourself first. What can I control? That's the first thing. Second thing is build the influence. And you can do that by showing them the reason why. Show them the one that has worked in your department. Show them how it can benefit them as leaders of the organization. Show them how it can benefit the organization. Show them examples of places that have worked, or places where your idea has worked, right? As I said, it's not easy. It takes a lot of actually doing the work, actually doing some research, right? Pull data together, pull information together. And I think with that, over time, like I said, it's not overnight. It's not something that happens like this. But over time, you'll be able to influence them and help them to see that things can actually be better. So, but I have some other gurus in the house who are very skilled at, who are very knowledgeable about changing people and changing mindsets. So if you have any other thing to add, please let us know. So, but that'll be my response. Thank you. Any other
Thank you, Dr.
question?
Vivian. We have a question here. Someone is asking,
Okay.
someone typed in the chat box, and can you hear me?
Yes.
Okay, and this person is asking a question.
Let me stop sharing and go to my
So
chat.
this person says, constantly anticipating potential risks, I feel might raise anxiety sometimes, even when you are doing the right thing. So his or her question is, what are the ways you can balance this? That is, even when you're doing the right thing, because you are constantly anticipating risk, it may lead to anxiety on the side of the nurse. How do you balance not being anxious and, trying to figure out if there is a risk or something?
Okay, so as I just said, sometimes we have to do the work in our minds first. That's a very good question because we're human beings, right? Imagine you only seeing the bad things. Definitely you'll be demoralized. Definitely it would affect your way of thinking. Definitely you don't even want to come to work the next day because you are so overwhelmed and all of that. So, but you need to talk to yourself. The essence of this is to make the system better. And as I mentioned, remember, very importantly, you cannot solve all problems at the same time, right? So yes, you are preoccupied with identifying the problems, but not all problems can be solved at the same time. And you don't need to feel bad for identifying the problem. You have to be happy that at least you have identified the problem and you have documented it. And you have 10 problems today, and you say, okay, which one out of these 10 should I focus on today? Right? So what should give you consolation is the fact that out of those 10, you have ticked that you have solved one problem or you have solved 2 problems in the last 1 week. Right? So the fact of being preoccupied with things going wrong is not to demoralize you. No, it's to be able to say, okay, how can we strengthen our system? And you need to keep that positive mindset. If not, even you cannot identify problems anymore if you go that route of thinking about it negatively. Okay, so first thing, we need to work on our own consciousness and our own minds. The purpose why we're doing this is to make the organization better, right? You can't solve all problems at the same time. Which one can I solve now, here, today? Focus on that. Tick it. Tomorrow you tick it off that you've done it. Which one can I do next? Gradually. It's a gradual thing. I hope that answers your question.
All right. Thank you, Dr. Vivian. It was such a beautiful presentation. You touched different areas, and I liked where you highlighted that we should always speak out. Communication is very, very important. Even when you're not sure, speak out, ask someone. If you don't know, ask someone. If you're not sure, ask someone. 2 good heads are better than 1. It's better a second person confirms it than you begin to assume or you begin to guess. Thank you very much. And we currently do not have any more questions. And thank you
I
once
saw
again
Chineye's comments. Yeah, thank you. I just wanted to highlight Chineye's comment. Very, very important. Celebrate small wins along the way. Very, very good. Yes, I agree with that 100% of the time. It will motivate you, motivate your team, and also show management that things are working. So thank you so much, IJ, and thank you everyone for your participation.
Thank you for coming around. All right, you can, to the attendees, you can access the course on Nova. In the chat box, you see where I dropped the links to Nova, our social media handles, our website, email. If you have any questions, you can email us. And also the link to how to get your certificate. There are steps to getting your certificate. Kindly check the chat and you'll see the step on. You can also access the out to you after the meeting. In about 24 to 48 hours, you're going to get the replay link. Thank you for participating in this session. And to other experts in the house, Dr. Yeniba and our active participant, Ugochi. Thank you so much for your contribution. And thank you to every other person who took our time to listen to us.
You're welcome. But sorry, can you hear me? Hello, can you hear me?
I can hear
Yes,
you.
we can hear you.
Sorry. I don't.
I
Are you
can